Good morning. I call this hearing to order. This year marks the 5-year anniversary of a watershed moment for VA and for this committee, the 2014 VA wait time scandal. Whistleblowers from the Phoenix VA healthcare system exposed an elaborate scheme by supervisors and senior leaders to conceal the amount of time veterans were waiting to receive health care. Some patients' conditions deteriorated, while other veterans died after waiting too long for VA appointments. After months of hearings and independent investigations, we concluded that serious appointment scheduling improprieties and delays in veterans' access to care were not limited to Phoenix, but were occurring at dozens of other VA facilities nationwide. And this had been going on for years. To address this, Congress passed the Veterans Choice Program in August 2014 with the goal of helping veterans access more timely health care by sending them to community providers. 5 years ago today, we held a hearing with VA's then acting Secretary, Sloan Gibson, and leaders from several veterans service organizations to learn how VA planned to restore the trust of veterans, Congress, and the American people. In his statement for that hearing, Mr. Gibson presented a stark but honest assessment of VA's challenges. 3 of the main challenges he identified are on this chart behind me: widespread scheduling improprieties, inadequate IT resources, and a culture of fear and retaliation. Honestly, after reviewing our witnesses' written testimony and several articles that have appeared recently in the national media, I'm alarmed that too much of what Acting Secretary Gibson observed 5 years ago still rings true today. This is frankly just unacceptable. We simply cannot put veterans' lives at risk while they wait for care. Today, it is time to assess VA's progress in earning back the trust of veterans, Congress, and the American people. Within the last couple of months, several media outlets published articles where whistleblowers allege that VA is still keeping secret waiting lists. This doesn't come as a surprise. Our committee staff also have been approached by several whistleblowers with these allegations, and some have faced retaliation after raising their concerns with VA. They allege that VA has mass canceled pending requests for certain types of care without sufficient clinical review, and that frontline employees have been ordered to schedule veteran patients in imaginary clinics as a means of concealing wait times. Some of these whistleblowers recently testified before our committee. Yet, as we learned from the whistleblower hearing that wrapped up yesterday, VA's Office of Accountability and Whistleblower Protection is failing to protect whistleblowers. We rely on whistleblowers to speak truth to power and hold VA accountable. OAWP must do its job and immediately end the toxic culture of retaliation at VA. Dr. Boyd, you claim in your written statement that, quote, no veterans were harmed, end quote, as a result of being on wait lists like those mentioned in the news. You also state that VA is operating with, quote, unprecedented transparency, end quote. Those are 2 very bold statements. With the Mission Act, more and more veterans will be eligible for community care. However, as you will hear from some of our witnesses today, VA has never reliably tracked or reported veterans' wait times for community care. Yet there is evidence that wait times in the community are often longer than wait times for VA care. VA's own data on wait times for appointments at VA facilities remain incomplete and unreliable. The policy goal of the Choice Act and the Mission Act was to reduce wait times for veterans and increase access. Therefore, the lack of accurate information on wait times at VA hospitals and with community providers should cause us all to question whether the policy to send more veterans to community care providers is sound or even if it's working. Veterans have a right to make informed choices about where to receive care. However, that choice is dependent on transparent and accurate information about wait times. This committee will not allow our veterans to be harmed by the same deceptive practices that led to the Phoenix VA scandal. I look forward to engaging our witnesses and my colleagues in on this conversation, and with that, I will recognize Ranking Member Dr. Rowe for 5 minutes for any opening remarks that he may have.
Thank you, Mr. Chairman. A little over 5 years ago, as the chairman stated, on April 14, 2014, this committee held a hearing very similar to this one on access to care for veterans in the Department of Veterans Affairs. During that hearing, then Chairman Miller disclosed that a committee investigation had uncovered a secret list, a waiting list at the Phoenix VA Medical Center, and that as many as 40 veterans on that list had died waiting for care. That disclosure embroiled VA in a nationwide access and accountability crisis that is still reverberating across the VA healthcare system today. We would be remiss if we did not take a moment to acknowledge the many ways in which access to care for veterans has improved since 2014. VA is seeing more veteran patients today than ever before. Last year alone, VA completed more than 1 million more appointments than it had the year before. In many cases, those appointments occurred faster within VA than they would have in the private sector, according to the Journal of the American Medical Association. We should all be proud of those achievements, particularly the thousands of VA employees across the country whose hard work is what led us to them. However, despite how far VA has come in the last 5 years, there is no doubt that VA has farther still to go. While I was preparing for this hearing yesterday morning, the VA Inspector General released an alarming report about delays in care for veterans seeking mental health appointments at the Albuquerque VA Medical Center. That report paints a heartbreaking picture of why we must continue to focus on access to care for our nation's veterans until we are assured that every veteran, every time, receives the care that they need when they need it. In a system as large and dynamic and as evolving as VA, there will never be a perfect way to measure access. It is as much of an art as it is a science. That is why I'm grateful to have the experts from VA and the Government Accountability Office and the private sector here with us today to discuss not only how access has improved for veterans over the last 5 years, but also how it can continue to improve for veterans over the next 5 years. I'm particularly grateful to have Dr. Kenneth Kaiser with us. Dr. Kaiser is a veteran of the United States Navy, a physician with a long and distinguished career as a public health leader in government, the private sector, and academia. He also served as Undersecretary for Health in the mid-90s during the last critical transformation period for the VA healthcare system. Thank you, Dr. Kaiser, for taking time out of your busy schedule to share your expertise with us this morning. I'm very much looking forward to your testimony and that of your fellow panelists. With that, Mr. Chairman, I yield back.
Thank you, Dr. Rowe. With us today are Dr. Deborah Draper, Director of the Healthcare Team at the U.S. Government Accountability Office, otherwise known as the GAO. We have also Dr. Teresa Boyd, Assistant Deputy Undersecretary for Health for Clinical Operations, accompanied by Dr. Susan Kirsch and Dr. Clinton Greenstone. We also have with us the Honorable Kenneth Kaiser, Chief Healthcare Transformation Officer and Senior Executive Vice President of Atlas Research Incorporated. With that, I will begin. We'll begin with Dr. Draper for her opening statement.
Chairman Takano, Ranking Member Rowe, and members of the committee, thank you for the opportunity to be here today to discuss VA's medical appointment wait times on the 5th anniversary of this committee's hearing following the Phoenix wait time crisis in 2014. While Phoenix was the epicenter of the crisis, the identified problems were widespread, affecting the entire VA healthcare system. Access to timely health care is critical for veterans seeking needed medical care. However, long wait times and weaknesses in the scheduling system have been persistent and have hindered veterans' ability to access care. For the past 20 years, we have conducted an extensive body of work on veterans' access to care. We have reported significant and wide-ranging weaknesses that contributed to the addition of veterans' health care to GAO's high-risk list for the first time in 2015 and where it remains today. In 2012, we conducted a comprehensive review of VA's outpatient medical appointment scheduling policy and processes. We found that the medical appointment wait times reported by VA were unreliable in part because VA did not ensure consistency in how schedulers recorded dates that provided the basis for measuring wait times. We found these dates to be subject to interpretation and prone to scheduler error. We recommended that VA clarify its definition of these dates. VA concurred and has taken some action since 2012 to improve wait time measurement, such as improved oversight through ongoing audits of schedulers. VA provided us new information related to this recommendation on July 12th. Once we have had the opportunity to fully review this information, we will be able to determine what additional actions and information are needed. However, at this time, we continue to be concerned that VA has not sufficiently addressed the reliability of its wait time data. For example, in its first internal audit in August 2018, VA was unable to evaluate the accuracy and reliability of its wait time data posted to its website for use by veterans. In 2012, we found that the medical appointment wait times reported by VA were also unreliable because VA did not ensure the schedulers received the required training. We recommended that VA ensure consistent implementation of its scheduling policy and ensure that all schedulers complete the required training. VA concurred with this recommendation and has taken action since 2012 to update its scheduling policy and complete training for schedulers. We believe that these actions, along with the additional information VA provided us earlier this month, sufficiently address this recommendation. While improvements to VA scheduling policy and processes will help ensure veterans timely access to health care, it is important to acknowledge that there are also other factors that may affect access that are not currently reflected in VA's wait time data. For example, we have found that VA's wait times do not capture the time it takes the department to enroll veterans in VA healthcare benefits, which we found could be quite lengthy. Issues with appointment scheduling have not been limited to VA's internal delivery of care, but have also existed for its community care programs. Our prior work on appointment scheduling VA's Choice program found weaknesses resulting in recommendations to address the lack of timeliness goals and reliance on incomplete and inaccurate wait time data. In June 2018, for example, we found that the data VA used to monitor the timeliness of appointments for the Choice program captured only a portion of the total appointment scheduling process. Although a VA had a wait time goal of 30 days under this program, the timeliness data did not capture certain processes, such as the time taken to prepare veterans' referrals and send those to a third-party administrator. We found that if those processes were accounted for, veterans could wait up to 70 days to see a provider. As of July 2019, our recommendations in this area have not been implemented. VA officials told us that these recommendations will be addressed by the tools and systems created for the new Veterans Community Care Program. According to VA officials, for example, one of the new systems that will support the management and monitoring of referrals, appointment scheduling, and authorizations will be fully implemented across all VA medical facilities in fiscal year 2021. In closing, we have identified weaknesses in VA's wait time measurement and scheduling processes over the years, affecting not only VA's internal delivery of care, but also that provided through community care providers. We have made a number of related recommendations. We are pleased that VA has taken actions to address some of these recommendations, but additional work is needed. The implementation of enhanced technology, such as a new scheduling system, is crucial and will provide an important foundation for improvements. However, this is not a panacea for addressing all of the identified problems. Moving forward, VA must also continue to ensure that its policies clearly delineate roles and responsibilities, oversight and accountability remain front and center, and training is ongoing and effective. Mr. Chairman, this concludes my opening remarks. I'm happy to answer any questions.
Thank you, Dr. Draper. We'll now turn to Dr. Teresa Boyd.
Good morning, Chairman Takano, Ranking Member Rowe, and members of the committee. I appreciate the opportunity to discuss VA's current practices for measuring veterans' access to health care and to provide a clearer picture concerning wait times in light of the 5-year anniversary of the issues in Phoenix. I am accompanied today by Dr. Susan Kirsch, Acting Assistant Deputy Undersecretary for Health for Access, and Dr. Clinton Leo Greenstone, Deputy Executive Director, Clinical Integration, Office of Community Care. VHA has undergone a tremendous transformation since 2014, operating with a renewed focus, unprecedented transparency, and increased accountability. We recognize that there are still challenges ahead of us, but it is important to keep in mind that veterans continue to receive the highest quality care, often with shorter wait times than in the private sector. As in the community, most VA patients come to us for routine or elective care. For established patients, VA's average wait times for primary care and mental health care appointments are under 5 days, and 7 days for specialty care. To ensure that veterans with more urgent needs are accommodated appropriately, as of 2017, the VA began offering same-day services for mental health and primary care at all VA medical centers and community-based outpatient clinics across VA. So what does that mean? Well, it means that when a veteran contacts us seeking same-day services for primary care and mental health care, we address the need that day with perhaps an appointment, if that's appropriate, by refilling a prescription, answering a question over the phone or by secure messaging, or even scheduling clinically appropriate follow-up care. We have also simplified the consult management process, and resolution of these referrals has made it easier for veterans to be seen in a timelier manner. When in 2014 it took an average of 19 days to complete a STAT consult, we are now completing these referrals in under 48 hours, which is the industry target. Listening to our employees and sharing strong practices across the enterprise, as well as lessons learned from implementing the Veterans Access, Choice, and Accountability Act of 2014, were among the reasons we have seen these improvements, and we expect continued success under the implementation of the Mission Act of 2018. As a learning organization, VA encourages employees who have ideas or concerns to report them. VA will not tolerate efforts to retaliate against employees for doing so. In January, VA Assistant Secretary for Accountability and Whistleblower Protection, Dr. Tamara Benzanto, was sworn in, and for the last several months, she and her team have been working closely with the VA Inspector General to ensure her office is operating as Congress has intended and with maximum efficiency. When it became apparent that VHA needed to improve the scheduling process, we created the Office of Veterans Access to Care, or OVAC, to lead VA's new approach, which has included updated scheduling software, standardized national processes, national audits, and scheduler trainings at the local level. More than 58,000 VHA employees, including medical support assistants, clinicians, nurses, and healthcare technicians, have completed this training, which includes technical and customer service skills, as well as in-depth training on standard processes and procedures per VHA's scheduling directive. Over the last 5 years, we have transformed how we deliver care, and our success has been realized due to strategic planning and cooperative implementation efforts across the enterprise, once again, listening to our staff, our veterans, and their families. Recently, OVAC implemented a 3-phase initiative to improve capacity, efficiency, and productivity to help facilities and our national teams better understand demand and increase access to care at specific sites. So overall, this work has helped us to improve access to high-quality care for our nation's veterans, more closely aligning capacity to meet demand. We also recognize that quality care comes from having adequate levels of staff available to provide and coordinate that care. Today, there are more than 200,000 healthcare professionals, including doctors and nurses, who treat veterans in the VA system. VHA values what veterans have to say, and we know that ultimately, it's our veterans who will determine whether we are meeting their expectations as healthcare partners. To better understand that perspective, VA has moved to the industry standard for assessing patient satisfaction, the Consumer Assessment of Health Providers and Systems Survey. Based on survey results, veterans are telling us we are moving in the right direction. VA has seen improvement in patient satisfaction scores across every category related to veterans getting care when they needed it. More than 77% of those who responded to the survey say they were treated as a valued customer during their most recent VA encounter. And 3 in 4 veterans say they trust VA with their health care. Placing veterans at the center of their care helps ensure they receive that care when and where they need it, and is fundamental to all we do. We have made significant progress and are committed to earning the trust of our veterans and the American people. We will continue to improve veterans' access to timely, high-quality care from VA facilities, while also providing veterans with more choice to receive community care where and when they want it. Your continued support is essential to providing this care for veterans and their families. Mr. Chairman, this concludes my testimony. My colleagues and I are prepared to respond to any questions you may have.
Thank you, Dr. Boyd. I now recognize Secretary Kaiser for 5 minutes.
Good morning, Chairman Chicano, Ranking Member Rowe, members of the committee. Thank you for the opportunity for allowing me to offer some comments about assessing and tracking wait times and timely access to care, and also to comment about what timely access to care means, or the evolving nature of what that means today. You have my written testimony, so I'm going to take the 5 minutes I have here just to highlight a few points that were made there. And I would note also that my comments here are informed by more than 40 years of experience in a variety of healthcare roles, from being a practitioner to managing the largest healthcare system in the United States, to being a researcher and a variety of other perspectives on issues related to access. Perhaps the first point I would make is that while assuring timely access to care is widely recognized as an important dimension of high-quality health care and has been a priority for American healthcare for many years, consistently achieving timely access to care continues to be a challenge throughout American healthcare. Unfortunately, long wait times for care are all too common for patients and families everywhere, although especially for those who are on publicly funded insurance, such as Medicaid. I think the problems related to long wait times are well known, and I won't go into that. Suffice it to say that when patients have to wait weeks or months to see a physician, bad things tend to happen. There are multiple reasons why we have problems in timely access to care in this country. Much has been written about this, and I won't take the time now to delve into all of those reasons. I would just note that one of the problems simply is the lack of national standards about what constitutes timely access to care in the variety of settings in which patients receive care. I would also comment that wait times, while seemingly a straightforward or simple thing to measure, actually technically turns out to be exceedingly complex and difficult to capture all the variables that go into wait times. And I would also note that even if wait times were accurately measured, they have many limitations. They are just one dimension of looking at access, and access is a multidimensional issue that includes many factors other than just wait times. I was gratified to hear that VA has moved to using HCAHPS as a patient-reported measure of timeliness of access. I would note that leading healthcare systems around the country are increasingly looking to patient-reported measures of timeliness of care, in addition to looking at wait times, but they find that patients' perceptions of the timeliness of care is very revealing as to how well their health system is functioning. And we can talk more about that later if there is interest. I think I would be remiss if I didn't also take the opportunity here to comment that in considering timeliness of care and how accessibility to care should be measured, we need to ask a basic or very fundamental question about what access to care means in an era of enhanced communication or enhanced connectivity through all of the information and communication technologies that exist today that, candidly, 10, 15, 20 years ago were simply not available. In a time when a large proportion of the population accomplishes many critically important and sensitive activities, such as their banking through the internet, we need to ask ourselves, why do we continue to view access to care only or primarily through the lens of face-to-face visits? And indeed, I would posit that measuring access to care simply by counting face-to-face encounters is increasingly anachronistic and really does not promote patient-centered care. We know that 70 to 80% of patients, when queried, would like to be able to take care of their healthcare needs just like they take care of their banking and shopping and other needs through technology-enabled devices. And when those folks are queried, more than 90% of them say that they are satisfied and happy with their interactions through telehealth, mHealth, other technology-assisted ways. And I would just, perhaps recognizing that the clock is running out, note that while VA is an acknowledged leader in telehealth and virtual care, I believe that it has only scratched the surface of what could be done to enhance access to care through technology-assisted means. And I offer in my written comments a number of suggestions for where I think VA could go and should go to enhance access to care using technology-enabled means and engaging entities like the National Academy of Sciences, Engineering, and Medicine and the National Quality Forum to help them with, address some of the technical issues attendant to getting there. With that, let me close and happy to respond to your questions.
Thank you, Secretary Kaiser. I now recognize myself for 5 minutes. Dr. Boyd, I'll begin with you. Where can veterans go to find out about the wait times to see a community provider?
So currently, the VA does not have a roll-up or even a provider-specific information about a specific community care provider.
Okay, so the VA doesn't currently provide that. So there's no way for a veteran right now to be able to assess how long it will take to see a community provider. When a veteran makes an appointment, is that veteran given information about the wait time to see a VA provider versus a community provider so they can make an informed decision about which is better?
So that's a great question, and I was remiss to not mention this, but all three of us, the physicians here from VA, practicing physicians within the VA at some time.
I only have so much time. I'm sorry, Doctor.
So I will
be
answer
rude,
that for you. I
but
will answer that for
It
you.
would seem to me that since you can't find out any times for a wait time for a community provider, that a comparison tool is also not possible. Is that correct?
What I will answer is this. In my conversation with my patient, which is very sacred, I do mention what our eligibility wait times are within the VA, and that's by the Mission Act. And I do discuss with my patient, you need to be seen within X, Y, and Z time. So it's the patient preference to go out to the community, knowing when that needs to be done, or stay within the VA.
But nevertheless, there's not really a tool or information available to say, this is how long it will take for the VA, this is how long it will take to go to the community.
So
you don't have that capability right now.
We have that within what we call our decision support tool that was rolled out on June 6th that all of our providers use when they meet with their veteran, with their patient, and they discuss their options for care.
But that's not available generally to the veteran outside of the outside on a website someplace, right?
That's correct.
So it's on the, and we haven't seen this tool independently tested for the accuracy of these comparative wait times.
Well, I could pass off to Dr. Greenstone, who is
Wait,
actually the developer of that.
I want you. Does the tool actually show wait times?
The DST does?
So, Mr. Chairman, the tool actually shows average wait times within the VA, and we're now beginning to collect data that we intend to put into the tool to show comparative data
an average
in the
over
community.
how long? An average over 30 days?
Yes, it's a rolling 30-day average that we actually show.
So at the point of consultation, you can't. There's no real-time comparison, within that day or the week for that veteran to know the real-time wait time at the facility, at the VA, or in the community.
That is correct. So that is determined at the time that a scheduler is working with the veteran.
So real-time wait times are not available. The average is available in a limited sense.
That's correct.
Our VA uses the Consumer Assessment Health Care Providers and Systems Survey mentioned earlier to collect data on whether a veteran received care when they need it. And it's the healthcare industry standard. Why isn't this information made easier for veterans to find, and why isn't VA publishing this same data from its community providers so veterans know if they can expect to receive care in the community when they need it? Dr. Boyd.
So currently, our veterans are able to look online. We have Access to Care website that our veterans can go online and look for their specific medical center or their CPAC.
I understand that, but I specifically asked you about the Consumer Assessment Healthcare Providers and Systems Survey data. My understanding is that VA does not publish this for community care providers.
That is correct.
Yeah, so, but why aren't we publishing that data?
Why? That is, I could pass it off to Dr. Greenstone, who is more informed about that particular part.
Dr. Greenstone, go ahead.
Sure. So we do not have the specific CAHPS data on the community providers. We have data on the veterans' experiences when those veterans go and see providers in the community. And we ask them the question about how satisfied were they with their community care experience with a provider in the
But
community.
I've heard testimony here that these consumer reports are actually a pretty good way to figure out how timely the service is. Dr. Kaiser, I mean, do you want to comment on this?
Well, a couple things I would say is one, that private providers, community providers, are not routinely required to report wait time data the same way that the VA is. And in the instances where some of that information is available, it certainly has not been subjected to the scrutiny for its accuracy and validity as has the VA data. The information on HCAHPS, while that could be gleaned from various sources and made available, that does tend to lag behind. Whether it is available in real time or close to real time may be more difficult to achieve. But some of that information is reported to the CMS and other bodies, and one could basically mine those data sources to get some of that information.
Well, thank you, Dr. Kaiser. Dr. Rowe, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Boyd, I guess one of the questions I have is that why does it take 3 months to enroll somebody in the VA healthcare system?
So I am not aware of the standard time for enrollment. We have multiple entryways for veterans to be enrolled. They can walk into a medical center, to the eligibility center, and sign up.
Well, it says, I mean, I read the script today, and it's the data in here, and it said that it did. Let me ask another question. So, and I read something in your testimony that I have a hard time believing, and I hope it's true, but I just have a hard time believing that it's true, is if you call up, you can get an appointment that day for mental health or for primary care at any CBOC and at any VA medical center, 172 of them in the country. Let me just ask you this question. If a patient calls up and says, I'm having real problems coping, I'm concerned about my safety, what does the scheduler tell this person, and what do they do? Do they get in that day? And if that's true, then what's going on in Albuquerque?
Okay, so that's a great question. It's about same-day services. So in that particular case, when that veteran calls into that clinic, the scheduler is not clinical. That would be handed off to a clinical person who would assess the needs with the veteran. Is this something that can be taken care of on the phone with another healthcare provider through telehealth, a video connect session, or is it of an urgent need and the veteran needs to go to more of an urgent care center or to an ER? So we assess the needs, and it is at every VA medical center and at every CBOC.
Well, my bet is that I'll get a call before the end of the day that refutes that. That would be my bet.
And Dr. Rowe, if I may add, 20% of our completed appointments every single day, and we look at this every morning at 7:45, so 20% of our completed appointments every day are same-day appointments. So it's those same-day service requests that actually go on to
Well, I think it's a
begin
noble
appointment.
goal. I mean, I absolutely do. It's just hard for me to believe it can be carried out. Now, the VA is seeing over 1 million more patients in 18 and 17, which is remarkable, or appointments, I should say. How's that occurred? Is it new hires? Are they not seeing a doctor? Maybe they're seeing a nurse practitioner, a PA, or something. How has that occurred? And then I've got a follow-up question.
So I'll be brief then. So in a myriad of ways, we look at efficiencies of the actual clinics and to make sure that our grids are open. That's how we schedule patients, to making sure that we're effectively supporting a provider, whether it be a nurse practitioner, PA, or a physician. And so we've found efficiencies. We've found some extra time in there for bookable hours, if you will. So that's part of it. The other part is, what we heard about telehealth. We have different modalities with which to actually see patients, if you will, to complete those appointments as well. So in some areas, we have increased staff because there was an increased demand, high growth areas, and also using the actual team around, say, our primary care team or our mental health team, not always having to be just the provider.
I guess the thing that I've looked at, and Dr. Kaiser, I'd like to have, you're absolutely right. I don't know that we ever measured wait times. I know I didn't in our practice. And if one of the measurements is somebody calls in to get a refill, boy, I did really well with that. If you look at those, if that's the standard that you're using, because I didn't even look at that as a contact with somebody that day. And typically how a private, and I'm sure it does at the VA too, works, at the end of the day, I'd have 15 to 30 phone calls that I would make to patients and contact them. When you talk about telehealth, I used to telephone. We didn't have a internet then, but I did that, and I guarantee Dr. Kaiser's done the same thing. Going forward, and I want to commend the VA for it is absolutely improved since 2014. There's no question about that. It's been a Herculean effort to do right by our nation's veterans. There's no question about that. And I've got, Dr. Draper, just a couple of very quick questions. My time's about expired, but what if you had today to improve the accuracy and consistency of this, what would you have the VA do today?
Well, I think they need not to consider this as a one-off like training. This needs to be consistent. I mean, one of the issues is that the schedulers are among the top 10 highest turnover positions in the VA. So it's, there's constant turnover. There's, really educating those schedulers and making sure that they're consistently implementing the scheduling policy. That's one big thing. Oversight and accountability, we continue to find pockets of that where that's not so effective. And that really needs, as I said in my oral comments, that needs to be front and center and just on the mind, pervasive on everything that they do. And I think that, the new scheduling system that is expected to roll out in the next couple of years, that will be very helpful, but that will not solve all the problems. You still have to, as I said, have training, oversight and accountability, and other things that, together.
Yeah. Just one last comment. The two most important people in my office was the first person to answer the phone when the patient called in to make that appointment, and the person that greeted them when they came in, because if they had a bad experience there, it was going to be hard to get a good clinical experience. So I would encourage you to do exactly that, is train those folks that are doing the scheduling and meeting people. They're the front line. They're the face of the VA. I yield back.
Thank you, Dr. Rowe. I now recognize Mr. Allred for 5 minutes.
Well, thank you, Mr. Chairman and Ranking Member Rowe, for holding today's hearing. I want to thank our witnesses for being here. Wait times for veterans in North Texas are too long. Every day, 40 to 80 veterans are in temporary care awaiting a bed at a VA facility. Now, that's why I led a bipartisan letter with my colleagues in North Texas to ask the VA to work with us in facilitating the acquisition of a donated hospital in Garland to help us meet the growing demand. This hospital is an easy solution to the growing access problems and will help with North Texas address the gaps in our capacity to provide for a growing number of veterans. So I'll ask you, Dr. Boyd, to take that back to your colleagues in the VHA and the VA. Secretary Wilkie has appeared before us in this committee and has said that he's interested in doing it. The Dallas VA wants to do it. The city of Garland wants to do it. And I'm a little bit frustrated at the amount of time that this is taking for this to move forward. It's something that we critically need to meet our capacity, and it's I think, the smart thing for the VA, for our veterans, and will save us a lot of money as well.
So if I could just briefly comment, I am in many meetings recently. There is an urgency with this discussion. I just want you to know, it is front and center. It has been discussed at all levels of VA and VHA. As you can only imagine, it's a very complex, sounds easy, but it's a complex discussion. But no doubt we want to do the right thing for veteran care. So so you know, we are working it.
Good. I'm glad to see that it's getting discussed. It's a matter of urgency, I think, and I'm glad that that you all are recognizing that. Texas is proud to be home to the most women veterans of any state, and yet wait times for women's healthcare services can be longer than wait times for other services. And I want to ask if you have a specific plan to address wait times for our women veterans.
So roughly, in working with our national program for women veterans, Dr. Patty Hayes, we are absolutely accelerating the footprint with which, if you will, the capacity for women-specific providers in all of our areas. And the other thing, just so you know, and I'm a Texan, by the way, the other thing is that when we recruit providers now, it is not perhaps do you want to do women's health? It is going to be something that's part of the recruitment package.
Yeah.
So I think that's another thing that we will do. But absolutely, we're very well aware of that.
Well, that's good to hear, because I think that we're going to have to continue to change and grow our VHA services to deal with our new community of veterans, and especially here in Texas with us having the most women veterans, it's a big issue for us. I want to also talk about community care, and I want to talk about how we're going to monitor this. I think you addressed it briefly. If you could go into a little more what the plans are, where we are in the implementation of that, and how we in Congress can help you oversee how the community care system is being enacted.
So I will hand that off to Dr. Greenstone, who can speak very eloquently about that.
Yes, certainly. Thank you very much. So, as you know, we've undergone a great deal of transformation overall in our programs. That's with new technology, new legislation under mission. We have new contracts that have been awarded and are now coming online, and a significant amount of change in our business processes for overseeing community care. That means we have the ability to now, which we never had before, using new technology in identifying the time that it takes for us from when a colleague or a provider like Dr. Kirsch or myself or Dr. Boyd places a consult, a request for care, to the time that care actually takes place in the community, and every important step along the way. And that way we'll have an opportunity to measure what matters. That means measuring that veterans are getting appropriate, timely, high-quality care. And when they're not, we have an idea now of where the problems are taking place. How can you really drill down and make the appropriate changes to actually improve upon the work that all of our staff are working on to improve getting veterans timely care? So that's going to be one of the ways we have the opportunity to oversee that data now.
Well, I hope you understand that this committee wants to work with you on it. We want this to be a success. I don't want it to also take away from our initial mission at the VHA, providing and improving the care we're providing there, as I said, to address our diversifying community of veterans. So I hope that you'll stay in touch with us. I hope that we have a productive conversation around this, because I've heard from some of our VSOs a lot of concerns about how this is going to be implemented, and so it's certainly going to be a focus for us here in the committee, and look forward to staying in touch with you on it. And with that, I yield back.
Absolutely. Thank you.
Thank you, Mr. Allred. Mr. Boss, you're recognized for 5 minutes.
Thank you, Mr. Chairman. This is for Dr. Draper and Dr. Kaiser both. The Journal of American Medical Association released a study in January, and they found the VA generally outperformed the private sector with respect to wait times. Are you both familiar with that study? And if so, do you agree with the findings?
Well, this is what I'd say. It's really a piece of the story, because it looked at 15 major metropolitan market areas, and we know across VA's 172 medical centers, there's great variation. So, and a lot of the access issues are more prominent for rural markets or rural, less urban markets. So I think it's important to really understand the implications or what happens in those markets as well, because as I said, there is a great deal of variability, as we all know, across medical centers. So I think it's a piece of the story. I think it also has implications for community care, because if the wait times are really, if they're worse in the private sector, then that suggests that VA is more able to provide care within its own facilities. But I would say the variability piece, and particularly looking at urban rural markets, is really important to consider.
Yes, sir. I am familiar with the paper, although it's been a while since I looked at it. I think it was a sound study, good results. As if I recall correctly, in the paper it did discuss some of the limitations that it has, and some of which have been alluded to already. But I would also take this occasion or opportunity to comment on something that Dr. Rowe made, as well as the person before you, and that one of the predictable and foreseeable problems that VA is going to have in assessing community wait times is the fact that there is no standard way of assessing wait times in the private sector. There are no national standards. There is no widely accepted or single way of doing this. So even though they may procure lots of information, there's no certainty that there's going to be apples-to-apples type comparisons, and so there's going to be difficulty comparing the information that is made available from community providers.
Thank you. And Dr. Boyd, you know, during the period of 2014 following the scandal of Phoenix, now have veteran satisfaction ratings increased or decreased, and with the VA, or do you think the wait times or is wait times a factor in that?
With regards to the tremendous increase in the satisfaction scores with our veterans, I think that the wait times have a piece of that, but really going back to what Dr. Kaiser was really, it's meeting their needs. So whatever that means, and that's, you know, to an individual, it may be different. And it could be, as Dr. Rowe said, it could be because they had a great experience too, an appropriate experience. But no doubt, our satisfaction scores are going up, and I do think that that is a piece of it. It absolutely is.
Well, let me just say that as members of the committee, all of us are wanting the VA as a whole to succeed and to be do their job to the best of its ability. That being said, each one of us have our own districts and see the particular VAs in our own district, and we use the scientific studies that we have, which is how many complaints come and say, how bad is our local VA in comparison to how many say, hey, they're doing a great job. And so as we do that, as we move forward, I hope that we find some kind of system which we can truly make that judgment call. I was a state legislator in the state of Illinois, and this is a scientific, we have a deer season. And the deer season and the amount of permits is released based on the amount of people who call in and say there's too many deer in comparison that there's not enough. And that's how they issue the amount of permits. I'm afraid that when we move forward with our veterans, that is not the really the best way. What the best way would be is truly find a way to track the numbers. And right now, I'm concerned that we're not able to track those numbers, and I hope we can get through that. So with that, Mr. Chairman, I yield back.
I now recognize Mr. Brindisi for 5 minutes.
Thank you, Mr. Chairman. Dr. Boyd, I recently had a meeting of my Veterans Advisory Council back in my district, and one of the issues that was raised by several of the veterans who attended the meeting was about the community providers under the Mission Act, being able to search them on the VA's website. But in an area like mine, which is very rural, and where high-speed internet is spotty at best and cell phone service is almost non-existent in certain areas, if you don't have access to a website or can't pull up the VA's website on your phone, how does a veteran go about searching what community providers are available under the Mission Act?
So just a couple of things for that. First of all, before we rolled out, June 6th Mission Act, we ensured that every VA medical center had the capability from the incoming phone lines to press 6 for more mission information. That's the one thing. But what you're asking is something that has a different twist to it as well. Veterans need to engage with their facility, with their VA clinic, their provider, in order to get into that system. There's no direct reaching out to the community providers. And that discussion then will be had at the VA center. So, and if Dr. Greenstone has anything to add on that, because he truly is in that area.
Doctor.
Thank you. It's a very important question, reaching out to our rural veterans who may not have access. And so clearly, like Dr. Rowe mentioned, the telephone is going to be one way that you can certainly get information. And if you contact someone, we can actually go to our directory and find out where that veteran lives and what kind of providers are in their sort of neighborhood, if you will, or close to them. But then, as Dr. Boyd mentioned, in order to access those providers in the community, it has to be initiated by a request for care from a provider within the VA. So that would be one thing. And then at that time, anytime you're working directly with a provider and a veteran, that provider has access to see the providers in the community, the average wait times in the VA, and eventually we plan on being able to demonstrate the average wait times in the community for a comparison to take place at that point in time.
Okay. So, and another question I wanted to ask was about the same-day services initiative. I want you to just expand a little bit on that initiative. Does that always mean a face-to-face appointment? Are there other areas where you can get help, telehealth? What does that exactly mean?
You're absolutely right, and I'll let Dr. Kirsch answer that. It's from her office, but you're absolutely right, and that's a super question.
Thank you for that question, and I wanted to provide some further detail in that this has been a pretty robust effort over the last couple of years to ensure that in primary care, mental health, substance use disorder, that we have the ability for a veteran to contact us and for us to take an action essentially. While, as we heard previously, 20% of the time it may result in a face-to-face appointment, we know, as has been pointed out previously, that this can be addressed through fulfilling a medication or assessing the patient and determining that that patient needs to be seen for some knee pain in 2 weeks as the appropriate follow-up. So it really is about addressing the need of the veteran that day, ensuring that there's not something urgent that is happening, and then ensuring that it happens in the way the veteran wants that. It's in a text message follow-up, or if it's in a phone call follow-up. That is our goal, is to be veteran-centric.
And just to follow up on that a little bit, in the written testimony, GAO said that ongoing staffing and space shortages have created challenges for implementing and sustaining same-day services. What are you doing to help those facilities with that challenge?
So overall, since 2013, we have increased staff very significantly by approximately 50,000 staff, and 63% has been an increase in schedulers specifically. Our office was engaged with GAO, and I think one of the report is not yet final, but the recommendation was really only around measuring what we do. As you heard previously, having a telephone follow-up or a secure messaging follow-up is not as easy to measure, and to roll that into and understand how we're doing in that area. And to that end, I have been engaged with the National Quality Forum to help assist us in understanding the best way to measure a same-day service.
Thank you. I see I'm out of time, so thank you for your responses.
Thank you, Mr. Modesi. Dr. Dunn, you're recognized for 5 minutes.
Thank you very much, Mr. Chairman. Dr. Kaiser, I read your resume, very impressive. You have great depth of experience. I too am a physician. I appreciate your insightful comments at the opening, on your opening statement there. So just doctor to doctor here, what do you think is the value of wait time measures as we're performing them in the VA, given the inherent technical problems in doing those measures, and are we guilty of an overly microscopic focus on a set of macroscopic problems?
Let me try to answer you in a couple of ways. I think wait times are an important metric to assess and to track. I think what many private or leading private health systems find is that they're more useful for quality improvement purposes. They're targets to try to achieve. That from an accountability or compliance point of view, just the technical issues make it very difficult. So while they are an important metric to track, they are but one metric. As I said before, it's a unidimensional way of looking at a multidimensional issue. Access is much more complicated than just wait times, and as Dr. Rowe.
I appreciate your saying that, and I wanted you to underscore that because I think it's important that we don't get too far out chasing down wait times. But on the same subject, are you aware of any wait time measure that is immune to faulty interpretation or scheduling errors?
No, I am not.
Yeah, I'm not either. Dr. Draper, are you?
Well, one thing that has greater accuracy is the create date, so that's a timestamp that the system creates, so it doesn't allow manipulation of dates like some of the other dates.
Good. I think there's a lot of things we could look at in the VA besides just wait times. Dr. Boyd, your testimony notes that the CHOICE Act, now the Mission Act, is a large factor behind many improvements in the department has made for access, recognizing that the implementation of the Mission Act really just started a few weeks ago. What impact do you think it's had on access so far, and what impact do you think it'll have going forward?
So in several areas, and you're right, we just started, but it seems like we've been living it now, in preparation. The access portion is that when we look at community care, our new community care network, as a senior leader, when I'm looking at the world of capacity of where my veteran patients can go, is a combination of my internal systems and my integrated outside network. So that is huge, and it gives veterans choices. There are no two veterans are the same with regards to where they live and so forth. The other part of mission that I wanted to thank the group for is that we have certain authorities now that will improve our ability to not only recruit, but to retain our employees. So that, to me, those two big things just stand right out.
So also, Dr. Boyd, on this note, the VA now provides many more appointments than it did back in 14. What do you attribute that capacity to, and what role do you think the community care plays in that?
So currently, we, year to date, we've had 1.75 million more completed appointments. That's amazing.
Year on
That's
year?
internal.
Is that year-to-year comparison?
Yes, sir.
Okay.
Yes, sir. So we're already 1.75 million ahead. And a couple of things, as I mentioned earlier, one is our attention to detail with regards to efficiencies. I too came from the private sector, and we didn't have a lot of fluff. People needed to have a good working environment, to have the good support so everyone could practice up to the top of their licensure. So we've paid really close attention to that through Dr. Kirsch's office with regards to efficiencies and productivity. That's a big piece of it. But I also want to believe that it is the regaining the trust of our veterans as well.
Well, that's good. I specifically sort of following the end of that question was the community care. What does it do for that? Increasing your ability to give appointments.
Okay. So having the options for our veterans in the community, especially for services that maybe in some areas they don't have.
Yeah, in rural areas
Rural
like
areas,
mine.
yeah, exactly.
Yeah.
Or there's not enough volume to support that service internally. We have a partner now in the community that we can coordinate that care, and that's that continuum of care that we promise our veteran patients. So
I appreciate that. So in my remaining 20 seconds, Dr. Draper, what do you think is our single biggest opportunity to improve access to care, and what do you think the biggest barrier to improving access to care is?
One of the biggest barriers, I think, is to have the sufficiency of providers to see patients. I mean, that's been an ongoing issue with VA, to the recruitment and retention.
But we sort of solved that with the community care, right?
Well, it depends on the community, I think. Some communities probably.
Fair enough.
I think it varies.
And the opportunity?
Opportunity for the biggest improvement.
Yeah, what's the biggest barrier? Well, I guess barrier and opportunity. I'll take that as an answer to both questions. Thank you very much, Dr. Draper. Mr. Chairman, I yield back.
Thank you, Dr. Dunn. Ms. Underwood, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to all the witnesses for joining us today. I recently surveyed veterans in my district outside of Chicago and learned that the vast majority of respondents are satisfied overall with the care that the VA provides, including the wait times to see a physician at a local facility like the Lovell Healthcare Center. Despite these local success stories, nationwide wait times remain a serious concern. Veterans prefer VA for many reasons, and we owe it to them to provide convenient, patient-centered access to quality care. Dr. Patricia Hayes, VA's chief consultant for women's health services, said in February that a, quote, small but persistent disparities, end quote, exist for women veterans accessing care at the VA. Overall, she said, quote, women veterans are still waiting longer for appointments than males, end quote. And so I know my colleague, Congressman Allred, touched on this, but women are a growing proportion of the veteran population. And Dr. Boyd, I believe it was Dr. Boyd, you said that, or maybe, yeah, okay, yes, that the VA is, quote, accelerating the footprint in all areas for women veterans. I was wondering if you might be a little bit more specific about the timeline to closing the gap in wait times.
I wish it was, said and done yesterday. But the reality is that with the enhanced recruitment capabilities, the authorities that we have within Mission, that will get us a little further. But as Dr. Hayes, I'm sure, has probably testified before, we continue to accelerate the mini residencies and to stay on top of women's health needs and their special concerns.
Right.
And so we're not losing focus on that. And we're actually integrating that even into our mental health world as well to make it an actual crosswalk, to make it part of the fabric as well. So we do have work to do. And I wish I had an exacting timeline, but as you know, Dr. Hayes, she will not let us, at all lose urgency on this one. And in fact, we just recently set up another governing board, if you will, that's primarily focused on women veterans and and to keep that fresh and also to keep the opportunities in line and in our mind with leadership as well.
Sure. I appreciate those steps. Are there any kind of internal goals or metrics that you all are working towards?
I would have to get back to you on that specifically and speak with her office on that.
Okay, please do.
I should be glad to.
Connecting veterans to timely care at the VA is especially important, as you said, regarding mental health and addressing the veteran suicide crisis. Some of our veterans will not self-report their suicidal ideations, which could limit the benefits of same-day care, right? They have to proactively say that they need to come in because they're having these kinds of thoughts. So, Dr. Boyd, does the VA collect data on average wait times for veterans specifically seeking mental health care treatments?
Yes, we do.
Okay. Mental health care is one of the several critical risk factors in addressing the suicide crisis. According to the CDC, access to effective clinical care for mental, physical, and substance abuse disorders can help protect people from suicidal thoughts and behaviors. Dr. Boyd, does the VA collect data on wait times for veterans wanting to be seen for pain management, substance abuse disorders, or other chronic medical conditions?
Yes, we do.
Oh, that's good. Okay, my last set of questions is in both the GAO and the VA testimonies, the need for consistent and comprehensive training of VA staff was highlighted. I commend the steps that you've taken to increase scheduling training completion rates and would like your perspective on how that was achieved. Dr. Boyd, how do you track the completion rates for staff who require scheduling training?
I will ask that Dr. Kirsch answer that for you. She has the specifics for that.
Thank you.
You're welcome.
Thank you for that question. Our office oversees scheduling policy, standardizing processes, trainings, and audits. And those trainings have been very robustly engaged with our 58,000 staff out there who do schedule.
So how do you track the rates?
We have our talent management system through the employee education system. It is trackable across all sites. It is on, you have to log in as a VA employee and complete trainings. But more important, or in addition to that, is really when anything, a nuance is brought up, or there are by communication calls every week with the scheduling
Can I
community.
ask one other follow-up question? Is there an incentive to complete the training?
It is an expectation as a component of your job that you complete the training, if that is in your job description as a role.
So it's in like your PDP?
Yes, it is.
I see. Okay, thank you so much.
Thank you, Ms. Underwood. General Bergman, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks to all of you for being here. This is complex, to say the least. You know, putting my airline pilot hat on from decades, you know, at one point we were graded on how much we supported our passengers to make sure they didn't miss their flights. The next time you turn around, we're being graded on our on-time performance. And as an airline captain, I had the challenge to decide, what do we do? The gate agents wanted to close the door, even though there were passengers running between flights, because they were going to get a ding on their record because of the fact that they didn't shut that door on time. My plan was and is always the passenger first. I said, I'll take the hit. If someone wants to call me as to why the flight left 3 minutes late, they can deal with me. And don't worry, I'll take you off the hook. So as we look at what we're trying to do here, which is not only identify wait times, but to accommodate our veterans who need care, it is going to be, again, a complex challenge to make sure that nobody gets hung out to dry for the wrong reason. So it's the accountability and the structure all the way up and down the line. Now, having said that, Michigan's 1st District, my home, is a combination of small towns, rural, and remote. So and you notice I didn't say urban or suburban. That doesn't fit. So when you think about wait times and what it means with the combination of services that we would have in our district with one small VA hospital in Iron Mountain, but a combination of C-Box, community care, it's kind of a microcosm of all other, not that big organized system that's within Uber distance. In fact, we don't have really much Uber in our district at all. Are we, in some cases, and by the way, anybody can answer this, are we in some cases comparing apples and oranges when we try to talk about wait times at a VA hospital, wait times at a CBOC, wait times in community care? I mean, are we we have separate silos here, and are we trying to compare, again, apples and oranges? Anybody want to take a shot at that one?
I'll start off. So when we go onto the Access to Care website, where our veterans can go on and look, if you go on and click onto Michigan, it will bring up it'll bring up the VA Medical Center and then all the clinics. And they'll have posted a 30-day average, and it is an average, of the wait times, if you will. And it's specific geographically and to that particular area. So I'm not sure if that answers your question.
Well, it does kind of wait. It kind of basically means that the comparisons, if you don't have big VA hospitals and you don't have you may fall outside of the 80% norm of that bell curve. Okay, I mean, we are trying to make here an 80% solution. If we can get 8 out of 10 right, think about even Ted Williams only hit 400. If we could hit 800, we'd be doing very well. I'd like to go down a different road here for a second. Can VA solve the problem that we're trying to deal with here, the wait times? Can they solve it from within? In other words, does VA have that capability? Or, said a different way, is there a model, Dr. Kaiser, that already exists somewhere outside of the VA that we can modify, again, to the 80% level to make it work? We're open to anything that'll work to make sure the veterans are realistic about what the wait times are, where they live, and for the condition they have. And we also want the VA and the CBOCs and the community providers to be realistic about what they can provide and not, I'd rather have them underpromise and overproduce.
Yes, sir. A few things. One, there is no model. No one has solved this problem. There is no single model out there that VA could just modify and adapt. There are glimpses of what we might call promising practices, and I'm encouraged to hear that VA has implemented and is pursuing a number of those, such as same-day service and what they've done in that regard. Certainly expanding telehealth and other technology-assisted options, which may be particularly useful in rural and underserved areas. But I also want to go back to your first point, underscoring the complexity of this issue and the need that exists for standards that are setting specific, whether that's primary care, specialty care, a hospital, a clinic, and all the different settings really have, we should be thinking about different standards for those settings of care. And there may be opportunities for the VA to engage with entities like the National Quality Forum or with the National Academy of Sciences to help solve or at least address some of the technical issues that may provide better answers for where we need to go in that regard.
Thank you, and I appreciate your answer. Mr. Chairman, I yield back.
Thank you, General Birdman. Mr. Pappas, you're recognized for 5 minutes.
Well, thank you, Mr. Chairman. Thank you to the ranking member and to our panel. I appreciate your testimony here today. I want to take a step back. We're marking 5 years since Phoenix. We're here having these discussions, talking about some steps that have been taken forward because of whistleblowers. And I noted, Dr. Boyd, in your testimony, you said, quote, due to the recent media reports of a whistleblower indicating issues with the electronic wait list, we conducted a top-to-bottom review. And I think that's great, but let's unpack that a bit. You say due to recent media reports, and I'm wondering why it took media reports and not a disclosure from a whistleblower with valuable information to spur that review.
So at the facility level where this may have occurred, there is always, that's just the practice. That is the ongoing practice is to always to look at harm, unintended harm, if you will. And it should not take a piece of paper, a story in the media to call our attention. We should be very responsive to when, as I mentioned, when employees or any staff, I don't care where they work and what their role is, comes forward and says something doesn't look right. So this is an ongoing practice at facilities to look at things that rise to the top. So it should not take a media story.
Well, I appreciate that, and we're working as the Oversight and Investigation Subcommittee. We've done a couple of panels on whistleblower issues. We want to ensure that they are heard, that we improve processes to protect their rights and prevent retaliation, which we have seen. We recently heard from a few whistleblowers in our June 25th session who raised some serious concerns that have a connection to the wait time issue that we're talking about today. The whistleblowers told us that they saw 12,000 canceled radiology orders in Iowa City, quote, imaginary opioid clinics in Baltimore set up to hide wait lists, and 400,000 plus consults opened over 90 days across 5 districts. I'm wondering what steps the VA is taking to identify and curtail any sort of practice of hiding and masking the problem that exists with wait times.
So it's multifold. One thing that is, I think, at the core is changing the culture. When I go around to sites, one of the first things that I do is meet with various staff, usually a town hall, frontline staff. Don't want leadership there, don't want supervisors there, to get a feel for, is there a good culture there? Is there a culture of, I will raise my hand and stop the line? So I think it really goes to us as senior leaders to walk the talk and to make sure that our facility leadership does that as well, because without that, we can have every possible process in place, but no one's going to feel comfortable raising their hand because no process is perfect. We want people to put holes in it. So it's all about changing that culture.
Well, thank you. Reading some of the terms that have been used with scheduling, I can understand why there has been some confusion. We're talking about terms like patient indicated date, desired date, preferred date, clinically indicated date. Is there a difference between these terms, or are they interchangeable?
I'll have Dr. Kirsch answer that one. Thank you.
Thank you for your question, and you bring up an important point, that is that names have changed over time. The patient indicated date was a decision made a few years ago, really with emphasis and focus on that it's about the patient preference in the equation. As a doctor, when I make it a follow-up appointment for a patient, and that's what patient indicated date is used for, it is between a clinical timeline when the patient should be seen, and then when the patient as well is agreeable to the appointment within a certain amount of time. That is what the patient indicated date is. It is evolved after the clinically indicated date and preferred date. It is now the replacement for follow-up appointments.
Okay.
I hope that answers your question.
Yeah, and I think that the GAO has indicated some improvement here at logging these terms, an 18% improvement in manually entering dates, but also there still exists an error rate that's of substance that has an impact. So I'm wondering, in terms of the GAO's perspective on this, how are we doing, and are they on track to be in compliance?
Well, since in implementing our recommendation, VA has taken a number of actions. One is biannual audits of schedulers, and the most recent, in 2018, they audited about 667,000 appointments, and they found an 8% error rate, so that affected about 53,000 appointments. So there is improvement. There's more work to be done, definitely, and I think that, as we talked about in our written statement, a lot of the scheduling, the terms are they're pretty much the same. They're just different. They're different names, but the patient indicated days, basically, it's the scheduler will use the clinically indicated data if a provider provides one, and if not, in the absence of that, they'll use the veteran's preferred date, which is essentially the same as the desired date. So not much
Thank you.
difference between
Thank
the
you,
terms.
Mr. Chair.
Mr. Banks, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Well, I'm encouraged by the JAMA study published earlier this year that found VA has significantly shorter wait times for primary care than private doctors. I remain concerned about VA's ability to provide urgent mental health services to our veterans in crisis. Dr. Boyd, in your testimony, you discuss how VA began offering same-day appointments for mental health at every VA medical center in CBOC in 2017. According to VA, when veterans request a same-day appointment, they are assessed for the level of urgency and either provided a form of consultation or a future appointment. I have a constituent veteran who had quite a different experience last year, and I'd like to take a moment to quickly summarize his story for you. This veteran was having a mental health episode and was found walking down the highway by police. The veteran was turned over to his mother, who picked him up and was instructed by a county VSO to immediately drive him to our local VA medical center for a mental health assessment. The VSO called ahead, but was informed that the local VA medical center didn't have room or a doctor that could see the veteran at the time. The VA medical center recommended that they go to the next closest VA facility, which was over an hour away. Upon arrival, this VA medical center also refused to see him due to, quote, lack of space. 2 police officers were in the waiting room and saw that something was wrong with the veteran and told the hospital staff that the veteran must be admitted, and yet they refused. The officers then went on and got a court order from a judge to mandate that the veteran be admitted. Dr. Boyd, this situation may very well be an outlier or an anomaly. And for all intents and purposes, I really hope that it is. But can you explain what VHA is doing to ensure that veterans in crisis are not being turned away and that these mental health assessments are available and consistent across all VA medical centers?
First of all, I want to make a comment. If in fact we have not looked at that particular case, I would appreciate that if your staff could get that to us.
Indeed.
If it happens one time, that's one time too many, okay? With regards to the process, we do have oversight of how patients are triaged and by what discipline. And when I mean that, I mean by social work, a licensed social worker, or a psychologist or psychiatrist. So our central office or our national program office meets regularly with the field. And when I say the field, I mean their regional leads who know exactly what's going on in facilities. So do I know for certain that there's not another one out there like that? I do not. That would be, it would be perfect if we did. But we make every intent to ensure that the urgency is assessed first. And so I have a lot of concern with the story that you just relayed to me. It doesn't fit with what we expect and what we see when I go out.
Yeah, very well. Dr. Draper, I understand that GAO has studied the availability of same-day services within VA, and we can expect the findings and recommendations of the report to be released soon. That being said, can you shed any light on how frequently situations like what my constituent experienced occur? And if so, do you have any recommendations for us on how VA can better prevent situations like this from happening in the future?
Well, according to the information, based on our work, that same-day services are available to anyone who comes into the VA and presents. I think there's some expectations on veterans because it's really intended for those with more urgent needs or more immediate needs. But We have heard from the facilities that we visited that basically any veteran can show up and get and request same-day services. So, so it seems out of character for what you're talking about, but I mean, I can't explicitly talk about that particular case because I'm not familiar with it. But one of the things I do want to clarify that I know that there's been information about that 20% of all appointments are same-day services. There's a lot of noise in that information, in that data. So, for example, it could include like a veteran, a provider will call in sick, and his or her appointments are canceled for the day, and then they get rescheduled with another provider. That looks like a same-day services when, in fact, the veterans may have been waiting quite some time to see the provider. So that's one instance. So that number is not as clean as it you know, it's not necessarily that 20% of all appointments are truly same-day services. It's also, I think, that there's some confusion about what same-day services are. It's not just a face-to-face with the provider, but it could be a nurse providing education, it could be medication refills, it could be scheduling a future appointment. None of those, other than the provider, face-to-face with the provider, none of those types of activities are captured. So we don't really know how much, what those different activities are and how frequent they happen. We did visit one VA medical center who had a pretty sophisticated group of staff who were able to set up a system, so they were able to track it, but that was just one facility that we saw that was able to provide information about the different types of same-day services.
Thank you. My time has expired.
Thank you, Mr. Banks. Mr. Cisneros, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Boyd, you know, like Mr. Pappas said, we've had several hearings, you know, regarding whistleblowers and those coming forward and how they've been treated after they come forward. And some of those whistleblowers are talking about the secret wait list that are being held at, you know, that has happened, and I guess Phoenix is our big example of that, of what's happened there. In your opinion, what can be done to increase transparency, culture, and you talked about the culture a little bit, and policy in the VA so that this recurrence of secret VA wait lists don't keep resurfacing?
Well, first of all, I want to be really clear. We are not 5 years ago. There are no secret wait lists. What we have are tools that are somewhat obsolete in their tracking capabilities that can be misinterpreted and really, so they don't fit the mold of what we had said back 5 years ago that truly were the wait list. And we don't need to go back and relitigate and re-talk about all of that. But what can we do moving forward? I think we're on a really good path moving forward. And I know it's the soft stuff, but we are on a journey of high reliability. And you may have already heard about this, where we're really focusing on a just culture and for zero harm and for raising your hand, stopping the line. Those who are the surgeons in the room or have been in the OR, that's extremely important, or even on the aircraft, right? Stop the line, something's not right. So it is a matter of doing that, of developing that through all of our 18 regions, our facilities, and in central office where we all live. It's a matter of providing that environment for folks to raise their hand and for us to say it's okay.
I get that, and I keep hearing that, right? How we need to adjust the culture at the VA, and there's a lot of work. You know, people are going to talk to the individuals, those that are working at the VA. You said it yourself. You're having town halls with those individuals. But what are we doing to talk to the supervisors at the facilities? They're the ones that are conducting the culture. They're the ones that are overseeing it all. How are we changing their mindset, and what's being done there?
And that's an extremely good point, since I did come from the field within the VA after private sector. We have not traditionally done a great job of setting our supervisors and mid-managers up for success. And you're absolutely right. There is a gap in there. And so part of this education or this journey that we're on is to give our supervisors, many of them new, and our mid-managers, the tools and the skill sets with which to be a successful supervisor, to be a servant leader. It is a rigorous program that we're embarking on, And you really touched on what I'm seeing in the field more and more. There is that mid-management gap. You're right.
Now, the other thing you mentioned too was that your tracking methods are behind. How are we going to update these? What needs to be done? How can we in Congress help you bring your systems up to date so we don't have these, archaic systems that are like 15, 20 years old and we're still trying to track things that way? How do we modernize?
So I'm going to let Dr. Greenstone talk about it because we are transitioning as we went from choice where we were purchasing care and had a much different process. And so we were using a tracking tool, a software. I'll let him talk about where we're going.
Well, one of the things that you raised is so important about secret wait lists and not having wait lists and have old archaic systems. So we are moving to new technology that allows us to actually put people, when we're using administrative lists, be able to have triggers automatically. Helping schedulers have triggers. So when in my realm of community care, when we're buying care in the community for veterans and coordinating that care, we have new commercial off-the-shelf COTS products that we've configured to work with our old systems so as not to lose integrity, but to have those new systems help our schedulers, for example, more effectively and efficiently get veterans care in the community and have little reminders that come up and the like, and drive those schedulers to follow policy. They can't go outside of their realm. And so eliminating things like the electronic wait list so it's not even available is things that we've done in the chairman's district recently to make sure that no one gets put erroneously on a list because we eliminate the list altogether. You can't even use it. And the technology allows us now moving forward to do those kinds of things, to have more guidance and more support and give the people the tools they need to be successful.
Well, I thank you all for your testimony today. My time has expired. Thank you.
Thank you, Mr. Cisneros. Mr. Roy, you're recognized for 5 minutes.
I thank the chairman. Thank you all very much for your time, and thanks for being here today. One quick question, maybe for you, Dr. Boyd, and then maybe you, Mr. Kaiser, as well. And I realize that we've had a number of hearings on this topic and will likely have more with respect to electronic health records. But a question, because it's something that I have raised to me all the time at Audie Murphy in San Antonio, as well as in Kerrville, Texas, is the extent to which the trouble with accessing records is interfering with, well, I'll say choice, now mission, and the ability to go get the care that veterans are seeking, and because of some difficulty in dealing with records. How much is that impacting wait times? I mean, we talk about wait times statistically, but in practice for a veteran, right, who's going in and saying, well, I want to get care, and they can't get care because they're going to seek care, and then they're having to get kicked back to the VA, and they're kind of in an infinite do loop. What can you say about that as its impact on wait times?
So I will let Dr. Greenstone comment on that, but that's an extremely critical observation.
Yeah, really important. So one of the things that we were able to create in terms of new information technology is it was taking our staff about 20 minutes on average to compile all the medical records that might be appropriate for a provider in the community to have access to in order to appropriately care for a veteran. We created a new tool we call the referral document tool, which allows the staff with several clicks to grab that information and put it all together in one document. And it actually saved 15 minutes of their time on average to be able to do that. And then how do you get it to them? So we have a new referral and authorization system that is essentially a portal. So the providers in the community, web-based, can log in and they can actually see the entire medical record of a veteran for the duration of the episode of care. So that's called our community viewer. So we've created ways in which we can facilitate getting the providers in the community medical information. We also need to get those records back. And so that interoperability is something that we're working on diligently. And one of them is using the Health Information Exchange. So if a provider in the community actually uses these new electronic records, they have the opportunity to create a computer-readable and human-readable document that the VA can actually pull and see readily, right, without having to worry about faxes and mail and all these other things. So they can use our portal, they can use the Health Information Exchange, the information back to us, and vice versa. So we're really trying to enhance this issue because it is a very important issue for us.
So you all would agree that has been a part of delays and wait times in the past?
I would say it would contribute. So if I'm a scheduler in the VA, I can see the exact schedule. So my scheduler can see my next available appointment. When I'm scheduling in the community, it may take longer because I may need to call 3 different cardiologists in the community. So it takes me longer to make that one appointment for a veteran in the community. So I can get fewer amount of schedules done in a day. So that does contribute somewhat to that process.
I appreciate that. Let me move on really quickly because limited time. Dr. Boyd, in your prepared statement, you noted that veterans often face shorter wait times in VA than in the private sector. Are there any regions of the country and or clinical specialties where VA is particularly challenged with respect to wait times compared to the private sector? And forgive me if you already answered that question.
Oh, that's okay. I would have to roll that up all free, but absolutely, there will be pockets in, we already heard from a few of the committee members, there are areas where we just don't have that expertise in-house, and there's very limited amount within the community as well. So we do have a fix for that. We have a solution, and that's going to be telemedicine is all through our clinical resource hubs. But you're right. But I don't have that off the top of my head, a long list.
Okay, that'd be great if we could get that in response to the hearing. Dr. Draper, a quick question for you. In your testimony, you reference findings, some of the recommendations that go back a number of years, going back to 2012 and so forth. Obviously, the VA health system has changed quite a bit over this last 6-7 years since that point. Are those findings, recommendations relevant today, and how would you comment on that?
Yes, absolutely. They still remain relevant. So our recommendations from our 2012 work was to really improve the reliability of the wait time measurement and ensure consistent implementation of the scheduling policy and scheduler training. So those were two that we have subsequently identified as priority recommendations. And then a third recommendation was something that Dr. Rowe had alluded to about telephone access. We have found telephone access to be problematic, and VA had a set of best practices that they never implemented, so that remains an open recommendation. And then the fourth one is to really identify the scheduling resources needed and allocate them appropriately based on need. So all those recommendations still remain open, and I will say we're going to close one of the priority recommendations, but it took 7 years to close, and so we're still moving forward. We still have 3 that are open for at least 7 years.
Thank you, ma'am. Thank you, Chairman.
Mm-hmm.
Thank you, Mr. Roy. Ms. Brownlee, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Boyd, you stated in your written testimony anyway that the VA, in a RAND study, it concluded that the VA performed similarly or even better than non-VA systems. And so I went back to find that report. First I want to say I want to applaud the VA because I think that data point is consistent with what I hear from veterans all the time is once I'm in the VA and getting my health care, I'm very satisfied. But this report had nothing to do with wait times. And I just want to make that clear. A few months ago, I had a town hall in my district, and the Greater Los Angeles people came in to my local town hall, and they read statistics on wait times for veterans in my district, and the whole room erupted in laughter. And I think the reason they erupted in laughter is because the definition of wait time from a veteran's perspective is polar opposite to how the VA defines wait time and how they measure it. A veteran or any average citizen would think wait time means from the time I called to ask for an appointment to when I received the appointment. That would be what their parameters of wait time. But yet, in the VA system, in a typical situation, the veteran will call and ask for an appointment. 6 or 7 days later, the VA gets back to them and says, yes, we want to see you. What's your preferred date? They give the preferred date, and then the preferred date can't be met. So, you know, that, let's say that on day 8, they said my preferred date is on the 13th. They can't meet the 13th, but the next available appointment is on the 18th. But the way the VA calculates that wait time is from day 13, the day that they wanted the appointment, and the day that they got it. So they say that's a 5-day wait time as opposed to all of the preceding days, which were, you know, 10, 11, 12 days before they were actually able to state their preferred time. So I think this is, you know, that's why my veterans erupted in laughter, because they were coming from a completely different perspective. So I just want to ask a very simple question, and I hope I can get a very simple answer. Why is it that the VA makes this so complicated and not just measure it from the time the veteran calls to the time he or she gets her appointment?
It's a good question. And Dr. Kirsch is here from that office. Be more than happy for her to take a stab at that one. Go ahead.
Thank you for that question. I want to make sure that I'm understanding whether it's a new patient or a follow-up patient.
Okay, I understand a follow-up patient can be a little bit different, okay? And so in this case, probably it's more relevant to a new patient, but I don't want to, I don't want anybody who's listening to this meeting think that there's a huge difference between one and the other. But go ahead.
I appreciate that. So for a new patient calling in to get an appointment, that patient then, the scheduler accommodates that patient if they're on the phone and they're ready to make that appointment. The time that the scheduler goes into the system.
No. I know how the system works.
Okay.
And I'm just asking, why is it that you don't measure from the time, whether it's a new patient or an existing patient, why don't you measure wait times from the time the veteran asks for an appointment and the time he or she receives an appointment? That's the only answer I want. Why is it that you don't measure it that way?
If the veteran calls and the appointment is made that day, until the completed time, that is the same measurement. I think there are some factors in there about request in a follow-up appointment where it's requested, and the time to reach to the veteran, call them, get back to them, determine when they want to be seen. There can be some variability in that component.
Okay, well, my time is up, and I just don't feel like I've gotten an answer. But I personally think, going to Dr. Kaiser's point and his comments saying that we lack national standards with regards to wait times, I'd love to have a longer conversation with you about what that should look like. But I just don't understand why it's not simple. Everybody keeps saying it's hard to answer your question because it's so complicated, but I feel like the VA has made it so complicated when it's really very simple from the time they call to the time they receive their appointment. I know I'm over time. I yield back, Mr. Chair.
Thank you, Ms. Brownlee. Ms. Radewagen, you're recognized for 5 minutes.
Thank you, Chairman Takano and Ranking Member Dr. Rowe, for holding this hearing, and I want to thank the panel for being here today. First off, I just simply want to associate myself with the concerns that were just raised by Ms. Brownlee, because in my home district of American Samoa, I go through this with our veterans all the time. And I'm very accessible to our veterans. As a matter of fact, many of them think nothing of calling me at 3 o'clock in the morning to tell me about their wait time definition that was misinterpreted or whatever. But at any rate, I do hope that sometime in the future, VA is able to find a way to simplify a very simple problem rather than doing it with a complicated kind of a definition. Anyway, so Dr. Kaiser, I understand that as the co-chair of the National Quality Task Force, you recently participated in a conversation with some of the country's top health experts about access to care in 2019 and how our increasing reliance on technology is changing how access is defined and measured. What were the key conclusions of that conversation, and how do they apply to our conversation today regarding access to care for veterans within the VA healthcare system?
Thank you for that question. I think if I were to distill down what was a perhaps several-hour conversation to a couple of points, it was this. One is that all of the utilization measures that are used to measure wait times have problems and are technically difficult. And as a result, many health systems are increasingly moving to patient-reported outcomes and what the patient perceptions are as to whether they got in a timely manner and how they were handled. And that while these health systems are not abandoning using wait times, they're using them in perhaps a different way, but putting increasing reliance on what the patients feel about the timeliness of the accessibility of care. The second point was the need to increasingly use technology-enabled means to facilitate access to care, whether it's telehealth or mHealth or secure email or a variety of other tools that are now available that simply weren't available not that long ago, and that, for example, Kaiser Permanente, as a system that sees more than 100 million outpatient encounters a year, are now accomplishing more than half of those encounters through various telehealth means. Los Angeles County, as another example, has gone to using e-consults to support its community-based clinics and has dramatically reduced wait times for specialty consultations by using, again, technology-enabled means. So I think if I, again, were to distill down a several-hour conversation, it would be to those 2 points about using patient-reported measures and using telehealth and other technology means to facilitate access to care.
Thank you.
And which has particular relevance to your district.
Yes. And going back to this definition of wait times, my veterans and I are extremely honored that Secretary Wilkie and I will be flying down in a few days to American Samoa. I'm sure he's going to get it in the neck about the definition of wait times. Dr. Boyd, please respond to allegations made by a VA employee, Jeremy Whiteman, in a June 3rd Washington Post article regarding the electronic waiting list. Now, are you familiar with that?
Yes, I am. Peripherally, that is an ongoing active investigation at this time, very complex. And if there were any other specifics, it's not a closed case yet.
Thank you, Mr. Chairman. I yield back the balance of my time.
Thank you, Ms. Radewagen. Ms. Lee, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank all of you for the service you provide to our veterans, and Dr. Kaiser for your leadership, Dr. Boyd as well, and GAO, of course, for your shining the light on this issue. Dr. Kaiser, while you were at the VA, you no doubt saw challenges that the organization experienced with technology modernization. And as of now, the VA has many modernization projects in process, including this transition to the electronic health record from the VISTA program. And it's our understanding that this transition will entail implementing Cerner's scheduling software, which will replace the current antiquated scheduling system. But this is going to happen nationwide at first, despite the fact that the Cerner rollout is going to be a step-by-step rollout over a 10-year period. And based on your past experience, Dr. Kaiser, what's your view of this transition, and what do you think the impact it will have on wait times and quality of delivery?
Thank you for the question, and I would certainly give the colleagues, my friends here from the VA, opportunity to respond after I try to address your your comments. I think there are two aspects of what you're asking. One has to do with the scheduling, the new scheduling system, standalone scheduling system that is being implemented concomitant with the implementation of the overall new Cerner electronic health record. I am encouraged by what I have seen so far with the scheduling system. I was particularly encouraged by the fact that the VA reached out to the National Academy of Medicine to hold a workshop on what should be the key operating characteristics and functionalities of that scheduling system. That workshop was held a couple of months ago. The report is, I got the draft actually of the report this week and should be released soon. And I think it will provide a lot of useful guidance to the VA as they implement this new scheduling system. As far as the rollout of the overall electronic health record, again, based on what I know and what I have heard from colleagues, and I do keep some presence in the IT sector, I have to confess that I have rather serious concerns about the implementation of the entire rollout and whether either the VA or the vendor is ready to accomplish all that needs to be done in the timeframes that have been laid out.
Thank you. I'd love to chat with you more about those concerns as well. Would anyone from the VA like to comment?
I'd like to address the Cerner standalone scheduling. As you know, that was a request last fall from the Congress about VA's plan in accelerating the scheduling component of our electronic health record. And we, since had purchased Cerner, spoke to the vendor about the capability and are collaborating with the Office of Electronic Health Record, VAOINT, and Cerner about accelerating that program. We believe that there will be benefits gained in efficiencies there and plan to begin that next June.
Okay, thank you. I just wanted to talk to Dr. Boyd, it might be Dr. Greenstone, on your written testimony. You cite the use of an online scheduling app. Are you referring to My Healthy Vet app? Is that what's being referred to?
So I can speak to that, sure, thank you. So there is a VA online scheduling, we call it VAOS, and that allows veterans to actually go in, and if they're established within a VA medical center, to request appointments and actually go in and make their own appointments in the grids of their primary care providers and even in mental health. We have created a similar capability for community care. So using Mission Act eligibility criteria, we allow veterans to go in to the VA online scheduling. It shows their ability to use this for community care if the system knows that that veteran has eligibility. They live in a state or territory with no full-service VA. They were grandfathered in under mission.
So is that done through this app?
Yes.
Yes, so it's
So the
done
app.
through.
So you can access it through My Healthy Vet.
Okay, and I just want to, do you have any idea about the utilization rate of this app by veterans? And what are the demographics of the veterans using it?
Dr. Kirsch may have that for internally. I don't have those data, but we can get those for you as we've just rolled it out for community care. But for internal VA, Dr. Kirsch may have some information.
No, I agree with that. If we could get that information back to you, because
Yeah,
that
that'd
is
be
very
great. And
telling for us as well.
Good, and I'd love if you could also, any information you have about the satisfaction and the effectiveness of the use of that app would be helpful. Thank you. I yield the remainder of my time. I think I'm over.
Thank you, Ms. Lee. Mr. Muser, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you all very much for being here. It's appreciated. Certainly, we're very encouraged by your work. What the Mission Act, I believe, has also helped improve. There's always more to do, and certainly our shared goals are to take care of our country's veterans to the best of our abilities with the highest level of quality health care. The number of VAs, Mr. Kaiser, I'll direct these questions to you, please. about 170 VA hospitals and 1,063 outpatient sites, are they all monitored for wait times?
I think it might be best that someone from the VA respond to that question.
Oh, all right. Would somebody like to respond to that, please?
Absolutely. We, on the accesstocare.gov website, veteran or family member can go in and look at wait times in primary care, mental health, and 10 other specialties for a new patient appointment. So,
Okay, Dr. Kirsch, I'll continue then my questioning with you. And is the rating system, is it the 4-star, 5-star? How do you set a rating system?
so that the rating system is applies to inpatient hospital care, and this Access to Care website is around receiving outpatient new appointments.
Is there a percentage of the VA hospitals, let's say, that are rated the best? Is there 5% that are in the top echelon for wait times?
We can identify which sites, because all sites do have wait times in primary care, mental health, and if they offer specialty services, we have wait times for every facility available, and we can provide that information for you and your staff.
Okay.
as needed.
Yeah, I would actually like to see that. And do you believe that the Mission Act has helped?
Absolutely. I think one of the biggest drivers in my role in leading the Internal Access Office has been to think about increasing our capacity, efficiency, and productivity really over the last year in preparation. We want to be able to offer veterans an opportunity to stay in the VA if that's their preference, or then provide an integrated, expanded network.
And Congressman, the other value to the Mission Act is the provision for urgent care. We've had over 14,000 veterans that we think have actually received urgent care under the Mission Act. So that's another way that we've expanded the capacity for veterans to be seen when they think they actually need care.
All right, great. And I do know the Mission Act, the Lebanon VA, which is in my district, Pennsylvania's 9th, does a fantastic job, and they're improving all the time. And they also get a tremendous amount of feedback from their veterans. I don't know if that's a customary practice in other VAs, Dr. Boyd?
Yes. With the Veterans Experience Office, we have an amazing tool now where it's called V-Signals. I mean, we can call it most anything, but we get real-time feedback, comments, congratulations, positive things, but we also get concerns from veterans real time, whether they're an inpatient or they're maybe that housekeeping didn't come in at a certain time, or they have concerns about medications, most anything. And we rapidly, well, the Veterans Experience Office rapidly gets those down to your site, down to your medical center, and your folks there, your leadership there, tend to that and address that, so they close that loop. We don't have to wait months for something to kind of fester. So we do real time owning that moment.
Okay, great. Are there certain model VAs? I mean, there must be that when it comes to wait times, or maybe it's many of the pieces of the overall operation that one VA or 10 VAs do better, and you identify the reasons why, people, process, technology, whatever it might be, and obviously do our very best to model the other VAs after them. Either one would be fine. Thank you.
So we do have, we call those best practices. I tend to call them good practices, and we want to socialize those rapidly, vertically and horizontally throughout our enterprise. And the way to do that is, as we're going forward with our VHA modernization plan, which I'd be glad to talk about that at some other time, where we are linking together like programs, like services, clinical services, and the facility all the way on up to the national offices, so we can help spread those practices. We don't have to wait for 2 years for a policy to come out, but share those things. So we do encourage that.
Well, thank you all for your service, and Chairman, I yield back.
Thank you, Mr. Muser. Mr. Levin, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank you for holding this important hearing, and thank you to our witnesses for the work that you do to serve our veterans. I particularly want to thank the folks at the VA back home in my community in La Jolla and in Oceanside for the excellent work that they're doing. There's always room for improvement, and with that in mind, I wanted to ask a few questions. Our veterans deserve clear information when making decisions about where to seek care, and Congress needs more reliable measures to understand veterans' access to care in our districts and districts across the country. Dr. Kaiser, can you speak to best practices for patient access measures across the U.S. healthcare system, and how commonly are wait times used as opposed to the CAHPS survey or other measurements?
As I indicated previously, there currently are no industry-wide or sector-wide standards that are used to assess wait times, which makes it difficult for an entity like the VA healthcare system to compare itself to community providers, because in the community a variety of different methods may be used, and certainly they don't receive the same degree of oversight or scrutiny as to the rigor with which their data has been collected, or how valid are the methods they are using. So there is some difficulty there, and in my written testimony, one of the suggestions that I offered is that the VA might want to work with the National Quality Forum to try to establish some national standards about what would be appropriate access standards or timeliness standards for the different settings of care, whether that be primary care or specialty care of different flavors, as well as hospital care and post-acute care, et cetera.
Thank you, and I appreciated that suggestion. I'm sure we'll follow up. Dr. Boyd, you also noted in your testimony that VA uses the CAHPS survey to assess patient satisfaction for primary care and for mental health care. Has VA explored the possibility of expanding this survey to other aspects of specialty care, and if so, can you walk me through the cost-benefit analysis?
I'll let Dr. Kirsch answer that, but we have some great answers for that.
Okay.
So mental health and other specialty clinics have been added in the last few years, so we can get information, and we do feed that information back through our group practice manager program. As a result of VACA 303 legislature, we have a practice manager, much like private sector, who is in charge of and really the point person for access at every single medical center. There are 238 practice managers that report to leadership there. So they really are overseeing and governing and looking at things like the V signals and the CAHPS information, can get you some specifics and follow-up for you and your staff around specialty care, cardiology, mental health, et cetera, and what are some of the questions asked and those responses nationally or locally.
Thank you. I'd appreciate that. I wanted to go back to this question of how dates are determined. As the GAO, Inspector General, and even VA's own internal audits have found, patient-indicated dates are often entered incorrectly, resulting in inaccurate wait time data. Dr. Boyd, I'd like to ask you a few follow-ups on this to kind of understand better how these dates are determined. You described the patient-indicated date as the appointment date agreed upon by the patient and provider. So what happens when the patient and provider disagree?
Goes with the patient's preferred date then.
Okay. How? Go ahead.
Because it's all about veteran preference. It really is.
That's what I was going to ask next. So how does the veteran's personal preference, such as a work or vacation schedule, factor into the determination?
It does. And if I can just allude, being from Texas, although I practiced up in Maine, up in the VA as well, and it was not uncommon for me to try to convince a veteran that, oh, you really do need to be seen in 45 days. Oh no, that was salmon running time up in the river, so couldn't do it then. So I used that because it was a reality to me that was important to that veteran. So we would push out the appointment and went to option B. So we do go with veteran preference.
Okay, thanks for that clarification.
Sure.
Dr. Kaiser or Dr. Draper, are there any other factors that you think VA should clarify?
Well, again, in my written comments, I suggested that the VA work with the National Academy of Sciences to try to define what access means in this era that we live in now of increased connectivity through advanced communications and information management technology. What access meant 10 years ago, certainly 15 years ago, is different than what it means today. And the fact that we can accomplish so many of our day-to-day important and sensitive activities through technology-enabled means has not carried over into healthcare. And there is much that we need to do to move healthcare as a sector into the same status, say, that banking and some other sectors have moved to as far as using the internet as a vehicle to enhance communication to services or connection with services.
Thank you, and I'm out of time, but I want to thank the chairman again for his attention to this important matter, and thank you all again for your testimony.
Thank you, Mr. Levin. Dr. Rowe, you're recognized for any closing remarks you might have.
Well, thank you very much, Mr. Chairman. It has been good, and I'm going to close by remembering a conversation I had over 4 decades ago when I started my medical practice. And this was an old country doctor that sat down and he said, "Son," he said, "I'm going to tell you how to be a successful doctor." And I said, "How's that?" He said, "I'm going to give you the 3 A's of practicing medicine. A number 1 is availability. A number 2 is affability. And A number 3 is ability." And he said, "You get those 3 right. If they don't like you, or if they can't get in, they don't know how good you are. If they don't like you, they're not going to come back." So that's a challenge that we all have. It's very, very simple, but it still works today. And like I said at the very beginning, you can do all these measurements if you want to, but when somebody calls in, they have a bad experience calling in to make an appointment, when the person that come in to greets them, when they come into the VA or into my office, makes them mad, I spend the first 10 or 15 minutes trying to get everybody calmed down so I can actually find out, why are you here today? So I think you can take those things in training and do that, whether it's in the private or the public sector. And secondly, Dr. Kaiser made several great points. And we do have huge challenges in rural America, where I live, in practicing medicine. And we know there are going to be huge shortages in the practice, and that's one of the things this committee did when we wrote the VA Mission Act. And it struck me when I was out in Greg Walden's district in Oregon a little less than 2 years ago, when he said, "My congressional district has more square miles than the state of Tennessee does." And it does, by several thousand more square miles, just one congressional district. So we had to put together a replacement of choice was something that worked in urban America and also tried to work in rural America, which is why you have to partner with the private sector. And one of the reasons for that is we know that the estimates are there'll be as many as 100 to 120,000 fewer physicians or lack of physicians in 2030 than there are today. And if we start training these doctors today, if you're a freshman in college today, you're not going to be ready to go live until the early 2030s to get your training done. So it was a huge problem. We also added in the Mission Act residency and how to pay for it. We know that medical debt is a huge problem, or debt, student loan debt, I mean, it's a huge problem. So we put that in there. A lot of things. So if you can't get your appointment at the VA in a timely fashion, can you get it out in the community where you live? If you live 5 hours from a VA and the doctor's sick that day, you don't want to drive 5 hours down there and find out I don't have an appointment, then turn around and drive 5 hours back. So those are the things that we tried to remedy making this, do it right in the Mission Act. I think that the VA, as a matter of fact, I can unequivocally say that between when I came on this committee in 2009 and now, the VA is doing a much better job. I really believe that. I think you're more attentive, and I believe that the solution to the problems is local leadership. If I'm a local VA hospital administrator or assistant administrator and I don't have the doctors, the personnel to take care of the patients that are going to be coming to my facility, I'm going to be recruiting those people. Number 2, if I can't get them, I'm going to go out in the community and recruit the community providers. I'm going to go out and say to them, to the cardiologists, "Hey, we're short here. Can you help us out?" And then what I'm going to do, because of the tools we gave you in the Mission Act, I'm going to pay you promptly so you'll continue to see VA patients. So I think it's a lot of things, but it has to be done not at the 30,000-foot level where we are right here today. It's got to be done at the local level, at the local CBOC. When I was out in one of the visits I made as a chairman, we're doing many of these, I realized that the incentives were different for a VA provider than they were for me in private practice. If I hired someone I got an extra night or two off call a week, a month. So that was a little more sleep that I got. I was highly motivated to recruit a new obstetrician, believe me. And our overhead didn't go up much. We could keep our overhead down. So those motivations are different. But the primary goal for all of us is to provide the best quality of care that you can possibly provide for that patient and a veteran. And to me, I'm agnostic about it. If it's in the VA system, I'm perfectly happy with that. If it's out in the community, I'm perfectly happy with that. I want the best care for the veteran. Thank all of you all certainly for taking your time and being here today. And Mr. Chairman, thank you for having this hearing. I really appreciated it.
Thank you, Dr. Rowe. Well, let me just say that we know that the VA, echoing Ms. Brownlee's remarks about the RAND study, we know that the VA offers excellent care as compared to private sector care. And so, you know, I'm not quite as agnostic. I believe the VA offers great care. The problem was access. The VA waitlist scandal posed serious doubts about access to care, and that scandal brought to light accessibility and manipulation of wait lists across the country. In response to that, we had put in place a piece of legislation, the Choice Act, that was intended to address these waitlist scandals and accessibility. As Dr. Rowe mentioned, we included medical residencies. We included money to hire people at competitive salaries. But what seems to be persistent is, frankly, a lack of transparency for the veteran in terms of being able to assess what are the wait times in real time at VA facilities. And there is no ability currently to really assess wait times at private sector community care facilities. And looming over all of this is what Dr. Kaiser mentioned, is a lack of any national standards or a common understanding of what wait times mean in the context of today's medicine. So I believe we have an opportunity for the VA to play a leadership role in terms of helping to set those standards. If VA can get that right, make it simple for veterans to understand, I believe we will do not only veterans a great service, but we'll do the American people a great service by setting these standards that the private sector, I think, will have to adopt as community care provider networks. Will have to also be just as transparent as VA healthcare. I remain concerned that we pay attention to building and maintaining the internal capacity of the VA to deliver the care that independent studies have said is excellent care. And we need to pay attention to efforts to increase accessibility to that internal care and to rely on our community partners to supplement what the VA cannot do internally. With that, I thank all the witnesses for their testimony today. I thank you for your hard work. All members will have 5 legislative days to revise and extend their remarks and include extraneous material. Again, thank you for appearing for us today, and this hearing is now adjourned.